This is another basic section on gonads and the adrenals. In this particular video, we'll be discussing more on the gonadal physiology, that is the reproductive physiology. This is essentially the same thing what you have been learning, or probably you have learned already from the first year of MBBS life, and we are just trying to consolidate and retread the facts once again. And understanding about this reproductive physiology is important again, probably in the future, understanding of your gynecological, endocrinological aspects like infertility, acne, and hirsutism pharmacotherapy. But still, these are very basic things and we have to understand that in the first place. And we are going to discuss about the hormonal aspects and what are the properties of FSH, LH, estrogens, testosterone. A lot of things are there in this video, so just pay close attention. So let us start with the very basics, the reproductive physiology of females, always ladies first. Let us start with the female reproductive physiology first. And you know that your reproductive physiology starts in the embryonic life itself at around 6 weeks of time, where your cells from the yolk sac reach the hindgut, and these cells from the yolk sac that reach the hindgut and they bud off, called as primordial germ cells, right? And these primordial germ cells, obviously, they have to move to the natural habitat, that is the gonads, and movement is mediated by multiple factors like this WNT4A and SDF1 and many other factors cause this movement of this primordial germ cells towards the gonads. In this case, it's going to be the ovary because we are discussing about the female with the XX karyotype. Once they have reached this ovary, further maturation and progression of the cycle of the primordial germ cells, and at the same time whether they stay within the ovary or not is going to be determined by a very important factor called STRA8 or STRA8, which acts on the retinoic acid receptor. So this STRA8 is the one that is going to cause further maturation of these primordial germ cells. At the same time, they are the ones that are going to prevent the primordial germ cells from leaking out of the ovary and to stay within the ovary in the first place. So now let us see what will happen to this primordial germ cells with a wider vision. This primordial germ cells, the chromosome depiction, I can write as 2N and 2C, which means I can draw like this. So I need a diagrammatic depiction as well. So I can write these are the 2 N's, which means 2 chromosomes, and you have 2 pairs of chromatids. Clear? So 2N and 2C. Now this primordial germ cells are going to undergo mitosis very rapidly, and they are going to produce millions of oogonia. This process is also referred to as oogenesis because they are going to produce millions of oogonia. What is the chromosome depiction of this oogonia? It's again 2N and 2C because here there will be DNA replication as well as cell division. So it will be 2N and 2C. Now there will be once again another mitosis going on, and they are going to form a primary oocyte after this step, and this process what we refer to as a oocytogenesis. But here the most important entity here, there will be only DNA replication, but there won't be any cell division, which means that gives rise to the chromosomal picture as 2N and 4C, which means I can write as something like this, which means I have the same 2N, that is N is 2 diploid, 2 chromosomes, but I have 4 chromatids. Clear? 2N and 4C, which means here because of no cell division, only the DNA is replicating, you get this 4C. So now this primary oocyte is going to go for meiosis 1. But remember, meiosis 1 will not complete though, but still it will start this meiosis 1. At the same time, there is one more event that will happen, that's called a follicular assembly. What do you mean by a follicular assembly? The ovarian cortex cells. So these are called as follicular cells, which are derived from the ovarian cortex, which form the follicular cells. These follicular cells are also referred to as progranulosa cells, and they surround this oocyte. For example, I can write This is the oocyte, and this oocyte will be surrounded by a single layer of flat granulosa cells, otherwise referred to as progranulosa cells, otherwise referred to as follicular cells. And they are derived from the ovarian cortex. Clear? If they ask you, ovarian cortex is derived from what? From the coelomic epithelium. And this is where the follicular cells origin as well. So, coelomic epithelium. And the important property of this follicular cells is the fact that they have this FSH receptors and they are highly sensitive to FSH, especially during the time of puberty. So that's why they are called as follicular cells, and the hormone is called as follicular stimulating hormone, because this hormone stimulates the follicular cells of the primordial follicle. So that is the reason. This entire arrangement where you have this single layer of flat granulosa cells or flat follicular cells with the primary oocyte is what we refer to as a primordial follicle. So in this example, I can tell this is the primary oocyte here. But we have already started the meiosis 1, but whether it will be complete or not in the primordial follicle, no, actually in the primordial follicle, it's not complete. And in the primordial follicle, there will be arrest of meiosis 1 at the diplotin stage of prophase 1. At the diplotin stage of prophase 1, the meiosis will be arrested. It will no longer continue. And this is the state of the primordial follicle till puberty. All these things have formed even before birth, but till the puberty, this is the fate of the primordial follicle. It will remain arrested in the prophase 1 until your puberty starts. So what is the number of primordial follicles? Remember, at around 5th month, the number of primordial follicles is approximately 5 to 10 million. At birth, the number of primordial follicles is around 1 to 2 million. And at puberty, the number of primordial follicles are approximately 0.5 to 1.5 million. Even though this number at puberty is widely variable according to textbooks, some textbooks give a number of just 40,000, some textbooks give a number of even 2 million, but this is the usual number that's given by majority of the textbooks. But it's really variable, and there is even a theory which states that the lower the number of primordial follicles at the time of puberty, the women will go for early menopause and a premature ovarian failure as well in some patients. And the larger the number of primordial follicles, they'll go for late menopause. So this is a theory that tells, even though not concretely proven, but you have to know that. But my question is, who maintains this primary oocyte in the meiosis 1 arrest, which means in the prophase 1. Beyond that, they will not progress. So there are a lot of research that has been conducted, and it's been proven that the G stimulatory pathway and thus increased levels of cyclic AMP within the oocyte is the one that prevents the oocyte to progress beyond this prophase 1 of meiosis 1. So how they have proven is, when they have taken the primordial follicle out, they completely and rapidly complete the meiosis 1, and if they incubate that primordial follicle in the solution containing phosphodiesterase inhibitors, which is going to increase the cyclic AMP, the primordial follicle continued to maintain its prophase arrest in meiosis 1. So that's how they, proved that the cyclic AMP is a very important mediator of maintaining this prophase arrest in the meiosis 1. So obviously this is the case, and all these primordial follicles are formed before birth itself, and they are going to wait till puberty, and they are not going to develop any further till puberty. And please understand, this primordial follicle is the basic functional unit of the ovary. That's a very, very important point. Basic functional unit of the ovary. During puberty, your hypothalamus is going to give signal to the pituitary by producing a pulsatile release of gonadotropin releasing hormone, and this pulsatile release of GnRH is one of the key points in stimulating the FSH and LH release, and continuous release of GnRH will not result in stimulation of FSH and LH release from the pituitary. In response to this signal from the hypothalamus, the pituitary is going to produce follicular stimulating hormone as well as the luteinizing hormone. This follicular stimulating hormone, as the name suggests, follicular stimulating hormone, this is the starting point of any menstrual cycle, and this is the one that triggers the onset of menstrual cycle, and this is going to stimulate the primordial follicle. I mean, the pyramidal follicle in the sense what they are going to stimulate this progranulosa cells, because these are follicular cells that are having FSH receptors and they are the ones that are going to respond to this FSH hormone. So this is the functional unit of the ovary. This is called primordial follicle, where I can see a flat single layer of follicular cells called as progranulosa cells, and I have a oocyte in the center. This is the primary oocyte, which is arrested in the prophase 1 of meiosis 1. So now once the pyramidal follicle is stimulated by the FSH, they further mature and they become primary follicle, and they further mature and they become a secondary follicle, and they further mature and finally they become a Graafian follicle or a tertiary follicle. So what's really happening here? But understand the fact that these pyramidal follicles are generally arranged in pools. Remember, even though there is no visible demarcation in the ovary as what pools they are, but as per our understanding, the pyramidal follicle are arranged in pools, and with every menstrual cycle, one pool will be selected. That's we know for sure. One pool will be selected for that matters for every menstrual cycle. For example, let us assume in the first menstrual cycle, this pool is selected. From the selected pool, many, not all, but many of the pyramidal follicles that are selected will enter the primary follicle stage, which will further enter the secondary follicle stage under the influence of FSH. But remember, only one follicle will enter the tertiary follicle stage, otherwise called as a Graafian follicle. So this is the final maturation step, but only one follicle for sure will reach the Graafian follicle stage. Remaining follicles, whatever they have selected, that are remaining, that have entered the primary and secondary follicle stage but could not be able to progress to the tertiary follicle stage, will go for atresia. Is there anything that selects, is there anything that is predestined that only this follicle should become a Graafian follicle? Nothing like that. Remember, suppose if this follicle is the one that becomes the Graafian follicle later, it's been clearly proven that this follicle is the one that has the maximum FSH receptors. Remember, the follicle with the maximum FSH receptor is the one that is destined to become the Graafian follicle or a tertiary follicle most of the times. Remaining follicles will go for atresia. When they will go for atresia? At the time of pool selection itself, some follicles may go for atresia. At the time of primary follicle stage, they can go for atresia. At the time of secondary follicle stage, they can go for atresia. We cannot be sure at what time they will go for atresia, but remaining will go for atresia, and only one will enter the Graafian follicle stage at the full maturation stage. Fine. So, for our understanding, let us keep it simple and think about only one follicle that is maturing over time and becoming a Graafian follicle. Remaining follicles, they may go for primary and secondary follicle stage. Anyways, they are going to go for atresia. We have selected this follicle, which is going to become a Graafian follicle. Right now, we wanted to concentrate only on that and understand. So, what happens in the next stage? That is a primary follicle. So, you have two stages. One is called the early primary follicle and second one is the late primary follicle. And you compare the primordial follicle with the primary follicle, you can see the prominent change that has happened is the granulosa layer has become more prominent. It should not be still called as zona granulosa, but it has become more prominent and it has become more cuboidal. That's what you have seen. It has become more cuboidal and it has become more prominent. That is under the influence of FSH. And the oocyte remains the same. It's in the primary oocyte stage only. There is no doubt about that. It's still in the primary oocyte stage and it remains the same. And in the late primary follicle stage, where under the influence of FSH, once again, continuous stimulation of FSH, now you can see the follicular cells or the granulosa cells have formed a definitive layer and they have proliferated nicely and they formed a definitive layer of zona granulosa. And the oocyte still remains the same, in the same primary oocyte stage only, where it is still in the meiosis 1 arrest. But what oocyte does is, it has secreted some content outside and it has made a clear boundary with the zona granulosa, and that is what we refer to as a zona pellucida. So this is a late primary follicle. This is a typical primary follicle. You have a zona granulosa and you have a primary oocyte and a zona pellucida, which is the secretions of the oocyte. And you can also see there is one more layer that is forming along with the granulosa. This is what we refer to as a theca layer, theca cell layer. And this theca cell layer is actually coming from the ovarian stroma. And where the ovarian stroma is coming from? They are coming from the urogenital ridge, otherwise referred to as a mesenchymal ridge. All these are MCQs in the exam. So ovarian stroma means some books also mention that they are present in the medulla, but I feel they are reti ovary, but some books mention that they are coming from the medulla. So in general, the basic origin is from the mesenchymal ridge or the urogenital ridge. From there, the theca cells come. Remember, the theca cells are highly responsive to luteinizing hormone, whereas the follicular cells or the granulosa cells are highly responsive to FSH. Similarly, these theca cells are highly responsive to luteinizing hormone. In response to luteinizing hormone, the theca cells are going to produce androgens, which under this influence of this granulosa cells, which means these granulosa cells have a very important enzyme called aromatase activity. And remember, the follicular stimulating hormone doesn't only stimulate the follicular cells, otherwise called as granulosa cells, to increase in number and size. They will also stimulate the enzyme activity within the granular cells, and one of the key enzymes of the granular cells is the aromatase enzyme, which will be stimulated by the FSH, and they will convert this androgen to estrogens. This is called two-cell hypothesis, where theca cell under the influence of LH produce androgens, and granulosa cell under the influence of FSH, they convert this androgen to estrogens because the granular cells have aromatase activity that will be stimulated by the FSH. So this is how you generate the estrogens, which means in the follicular phase, your estrogens are going to steadily increase over time. So let me tell you what is the importance of the estrogen increase, because this estrogen increase is really important for two reasons. One, you're going to result in LH surge. For this estrogen increase is really important. At the same time, in the endometrium, you have to encounter a proliferative phase, which means the cells are going to increase in thickness. That's called zona functionalis, which will develop, and that is going to increase in thickness. So that is the importance of this estrogen. So estrogens are important for endometrial stimulation, which means endometrium will enter the proliferative phase under the influence of this high estrogen. At the same time, in the late follicular stage, there will be LH surge. For this luteinizing hormone surge also, these increasing estrogens are really important. Now the primary follicle will enter the next stage of maturation called as a secondary follicle. The events are the same, but the most important thing that differentiates the primary follicle from the secondary follicle is this fluid accumulation that happens within the granulosa cells, which is referred to as a antrum, right? And this fluid accumulation is going to become more and more in the next stage, but right now this is what we refer to as an antrum. But remaining events are the same, where you have granulosa cells which are much more increased in number here because of the effect of the FSH, and you have the same theca cells, and the granulosa cells and theca cells are going to hold hand in hand, where the theca cells are going to produce androgens which will be converted to estrogens by the granulosa cells. And you can also see even more prominent zona pellucida here, and the most important thing that has happened is this fluid accumulation. And this fluid accumulation also has brought about another group of cells that are surrounding this primary oocyte. And remember, the primary oocyte still has remained the same, and its nuclear material is also the same, and it is still in the meiosis 1 arrest only. And this group of cells that are surrounding the primary oocyte, and they are nothing but the granulosa cells only, but they are separated from the remaining granulosa cells by the fluid in the antrum, right? So these granulosa cells that are now surrounding the oocyte is what we refer to as a cumulus oophoricus. It's a name, cumulus oophoricus. Now they go to the next stage of maturation called as a Graafian follicle. Other names for this Graafian follicle is the tertiary follicle or a dominant follicle. Remember, as I told you before, many number of follicles may enter the first the second stage. There's a primary follicle and the secondary follicle stage, but only one follicle generally matures and becomes the Graafian follicle, and that follicle is the one that has the maximum FSH receptors. Now the changes are even more prominent here. Now the fluid has accumulated so much and it has covered the entire oocyte, and to an extent that the oocyte is pushed to some corner, isn't it? Oocyte has been pushed to the eccentric location, and at the same time your granulosa cells also has been pushed towards the side, and your theca cells are even more cornerized, and you can see the theca cells and the granulosa cells are forming the outer layers, and you have a fluid in between, and you have a oocyte, and you also have a prominent surrounding cells that are surrounding the ovum called as corona radiata now. Corona radiata. Clear? So which means these corona radiata cells are nothing but granulosa cells that are separated from rest of the granulosa cells by the fluid. In the previous stage we called it as cumulus oophoricus. In this particular stage we are going to call it as a corona radiata. Nothing much. And you can see the zona pellucida here clearly again, and you can see the oocyte. So here the oocyte will go some maturation process, like how the follicle has gone for maturation process. Now the oocyte also has to go for maturation process, but for the oocyte to mature, you need that LH surge. Clear? So remember, this increased estrogen in the late follicular stage is important for the LH surge. I already told you in the basics of the endocrinology, this ovulation is one of the important positive feedback mechanisms happening in the body. Usually increasing estrogen should suppress the LH and the FSH, isn't it? But in the late follicular stage, if the estrogen goes beyond a particular level, so that will actually result in stimulation of more and more release of LH, and this is a positive feedback mechanism. And estrogen shifts its role from being a negative feedback hormone to a positive feedback hormone in the late follicular phase. I mean, if it goes beyond a particular level, which I'll be discussing in some time, and that is going to trigger the LH surge. So what are the things that happens because of the LH surge? Remember, LH surge, the most important thing that will happen is the ovulation. But for this ovulation to happen, it takes 24 to 36 hours in general. Remember, in this period of 24 to 36 hours, there will be some changes that happens in the primary oocyte, where this primary oocyte will quickly complete its meiosis 1 and is going to become a secondary oocyte, which means it's going to complete the meiosis 1. Till the time it was in the prophase arrest, isn't it? Now it has completed the meiosis 1 and has become the secondary oocyte. Obviously, meiosis is something like making the chromosome number into half. So you know the chromosomal depiction of a primary oocyte is 2n and 4c, whereas the secondary oocyte will have half of the chromosomes, that is n and 2c. Where are the remaining half? The remaining half will be extruded in the form of polar body. So the polar body is the one that receives an unequal and disproportionate cytoplasm, but it receives the equal nuclear number, equal genetic material, but it will not receive enough cytoplasm to survive and thrive, and it is considered useless, and it will also contain the same amount of nuclear material, that is N and 2C. But what is important for us is the secondary oocyte only. And this secondary oocyte will also quickly start its meiosis 2 during this 24 to 36 hours, in that time where the ovulation is about to happen. But remember, this meiosis 2 will not complete, and it will be arrested in metaphase. So it will not complete further. To complete the meiosis 2, the secondary oocyte must get fertilized. Otherwise, it will not be completed. That's a very important point. So ovulation happens, right? Because of LH surge. So LH surge triggers the maturation of the oocyte. At the same time, the LH surge is going to trigger ovulation once the oocyte has matured. Because that 24 to 36 hours window is where the primary oocyte becomes secondary oocyte, and quickly they are going to complete the meiosis 1 and they are going to enter the meiosis 2, where it will be arrested in the metaphase. If the ovulation has happened, so obviously the most important factor, as we told, that determines this ovulation is the LH surge. So because of this LH surge, your ovulation has happened and you're going to extrude this secondary oocyte out of the ovary. And the extruded secondary oocyte will look something like this, where you'll have a zona pellucida, which is very prominent. At the same time, you'll be having a corona radiata. This corona radiata is nothing but granulosa cells that are separated from rest of the granulosa cells by the fluid that is separating them. We have discussed that already. So, and the oocyte will be now called as secondary oocyte, and you can see the first polar body, which is obviously we know it's not going to be that useful for our understanding anymore. So that has received an unequal cytoplasm and that has almost on the verge of dying. And this fate of secondary oocyte will depend on whether it gets fertilized or not. Suppose if it is not fertilized, which is a very common scenario. Suppose if this secondary oocyte is not fertilized, it will wither and die in 12 to 24 hours, which means its lifespan is only for the next 12 to 24 hours. Suppose if the secondary oocyte has been fertilized, actually once it extruded, it can be called as ovum also. By varying degrees, it can be called as an ovum. Now it is fertilized, it's called as a fertilized ovum. Once the ovum is fertilized, there will be further changes in the ovum that is happening. I mean, before this fertilization, the ovum or the secondary oocyte has arrested its meiosis in the metaphase. Clear? So now it's going to quickly complete the meiosis 2. So once it completes the meiosis 2, now the fertilized ovum's nuclear material will become N and C. Previously it was N and 2C, now it has become N and C, which means the remaining nuclear material, another N and C, will be extruded in the form of second polar body. I can write as polar body number 2. So this will contain the remaining nuclear material. Again by the same principle, because of unequal division of the cytoplasm, one will receive maximum cytoplasm, that will become the fertilized ovum, and then another one will receive the least amount of cytoplasm, but with the equal nuclear material, that is a second polar body, which is not going to be useful anymore for our discussion. This fertilized ovum, once it mixes with the sperm's nuclear material, which also contains N and C, now it will become 2N and 2C, right? Back to square one, where the mother's nuclear material and the father's nuclear material has mixed with each other and they have produced the diploid chromosomes back to the square one, 2N and 2C, where the primordial germ cells are the diploid chromosomes, isn't it? 2N and 2C. So this is what happens, right? What is the fate of the Graafian follicle? Which means the Graafian follicle is still in the ovary. Like only the oocyte has been expelled and the ovum has been expelled, and the remaining granular cells and theca cells are still in the ovary. What is the fate of that? This Graafian follicle slowly starts becoming corpus hemorrhagicum. Because of the expulsion of the oocyte, there will be a local blood clot that is formed, which slowly becomes an endocrine organ, which is also referred to as a corpus luteum. Both are almost the same. So this corpus hemorrhagicum and corpus luteum, the most important function is to secrete progesterone, because this progesterone is going to prepare the endometrium and to increase the glandular secretions that prepares the endometrium for implantation if at all the ovum is fertilized. Suppose if fertilization has not happened and the support from the FSH and LH is lost, because you know that your progesterone is going to increase, and they don't only secrete progesterone, they are also going to secrete estrogen also. This estrogen and progesterone will be in moderate amount, so obviously they will be giving negative feedback to the pituitary, and they will be having lower amounts of FSH and LH during this phase. If they have lower amounts of FSH and LH, your support for the corpus luteum will be lost, because this luteum is mainly formed by the stimulating effect of luteinizing hormone, isn't it? That's why luteinized the graphene follicle to produce the corpus luteum. The LH surge is the reason for all this. So now, because of declining support from FSH and LH, the corpus luteum will no longer sustain and they will become corpus albicans. Clear if the ovum is not fertilized. Now, the corpus albicans will no longer secrete progesterone. Progesterone will be lost. At the same time, estrogenic support also will be lost, which will result in shedding of endometrium in the form of menstrual cycle, in the form of menstruation, blood loss. But suppose if the ovum is fertilized, remember this zygote, this fertilized ovum now, once the sperm material is mixed, this 2N and 2C will be now called as a zygote or an embryo. Now the zygote or the embryo will be starting to produce something called a beta HCG. And this beta HCG has multiple functions as we are discussing, but this is also important for sustaining this corpus luteum. So even though the FSH and LH are low, but they will sustain this corpus luteum through beta HCG, suppose if the ovum is fertilized. If the ovum is not fertilized, beta HCG will not be produced. So because of declining FSH and LH support, they will go for corpus albicans and there will be no longer progesterone production and they will shed the endometrium and they will produce the menstruation. But if the ovum is fertilized, this beta HCG will now sustain the corpus luteum even though there is no LH, and the corpus luteum under the influence of beta HCG, obviously they are going to be surviving for almost 12 weeks till the placenta takes over as the significant producer of progesterone, because progesterone is one of the most important hormones in pregnancy. Now, like, I don't know how to tell it. You don't have the entire adrenal gland. You don't have your cortisol, fetus will survive. Only postnatal they will have the problem. You don't have the entire aldosterone production in the fetus will survive, and only postnatally they will have salt wasting. You don't have the DHEAs at all, still the fetus will survive. Maybe there could be some issues, but still the fetus will survive, even if there is no DHEAs at all. But if there is no progesterone, the fetus or the embryo cannot survive and the pregnancy cannot be sustained. Progesterone is such an important hormone. Clear? So for the first 12 weeks, the corpus luteum will produce progesterone in pregnancy under the influence of beta HCG, which is coming from the embryo. Suppose after 12 weeks, the corpus luteum will anyway disintegrate, and now the progesteronic support for the endometrium will be done by the placenta itself, and the placenta will take over in the second and the third trimester. Till the first trimester, corpus luteum is really important and it will be sustained by the beta HCG coming from the embryo. Clear? So these are the basic physiological aspects that are happening, and let us summarize what all we have seen, and let me go to some images. So there are two phases. This is the ovarian cycle, because your menstrual cycle is made of two things. One is the ovarian cycle and the endometrial cycle. Ovarian cycle has follicular phase, approximately of 14 days duration, physiologically speaking, and you have a luteal phase, formation of corpus luteum, which is having another 14 days. Remember, ovulation happens at the end of the follicular phase, right? So at the end of the follicular phase, ovulation happens, and ovulation will mark the end of the follicular phase and the beginning of the luteal phase, right? So what is the important hormone in the follicular phase? Estrogen. Estrogen is one of the very, very important hormone in the follicular phase. Just prior to ovulation, your LH surge will happen, and that is really important. And FSH is the starting for the follicular phase, and that is also very important to understand. And in the luteal phase, the most important hormone that is secreted is progesterone. Plus, obviously, estrogen will be produced, but progesterone is the one that is maximally produced in comparison to the estrogen. And FSH LH will generally be low in the luteal phase. There will be corresponding changes in the endometrium as well, because there is a separate endometrial cycle going on. In the endometrium, there is a phase that corresponds to the follicular phase of the ovarian cycle called as proliferative phase. And there is also a corresponding phase that is corresponding to the luteal phase of the ovarian cycle called as secretory phase. And we know what is the most important hormone in proliferative phase, that is the estrogen. That is the one thing that favors the endometrium to go for proliferation. And the most important hormone of the secretory phase is obviously progesterone, which makes the endometrium more secretory and prepares the endometrium for implantation, which can possibly happen in that particular period. Clear? Let us see the hormonal interplay now. So remember, you have a group of primordial follicles that will be selected to, some of them will go towards secondary follicle stage, some of them will go to primary follicle stage, but only one will enter the Graafian follicle stage, and that is what we call as the selection of the dominant follicle. And to select this dominant follicle, you need this FSH, and that is the reason why FSH has two peaks, one on day 6. This is to stimulate the initial cohort of follicles, that is the primordial follicles, to enter into the subsequent stages, right? Then for the final maturation of the Graafian follicle, you need another bout of FSH. That's why FSH increases again at around the day 12 mark. So there are two peaks of FSH. One is at day 6 to select a cohort of primordial follicles to push them towards the further stage of maturation for the menstrual cycle to happen. And at day 12, it happens to make the dominant follicle, like to make the maturation of the secondary follicle, and one follicle will be pushed towards the dominant follicle or the Graafian follicle. For that, you need this FSH peak again. So that's why it peaks again in day 12, to be honest. And you can see there is only one peak of luteinizing hormone that is happening. So that one peak of LH is really important for multiple reasons. One, because it's going to induce ovulation, which is going to happen after 24 to 36 hours. At the same time, it luteinizes the Graafian follicle, which means once the ovulation happens, this luteinization of the Graafian follicle is important because that is going to secrete progesterone. For that, you need that LH. It has to prepare that Graafian follicle to get luteinized to secrete progesterone in the luteal phase. And at the same time, this LH is the one that causes this changes in the primary oocyte and formation of the secondary oocyte. You have a lot of importance of this one single LH site that's happening pre-ovulatory, 24 to 36 hours prior. And estrogen, generally it has two peaks. The first peak happens just before the LH surge, and that's really important because this estradiol peak is the one that is responsible for the LH peak because the positive feedback effect of the estradiol at a very high level. So if they ask you the gap between the estradiol peak to the LH peak, I can tell it's somewhere around 12 to 24 hours. 12 to 24 hours later, your LH peak will happen after the estradiol peak. And it has a second peak in the luteal phase also. Obviously, your corpus luteum is not only going to secrete progesterone, they are also going to secrete some amounts of estrogen as well. But the estrogen is more important in the follicular phase compared to that of the luteal phase. The most important hormone in the luteal phase, we know it's the progesterone. This is the single most important hormone in the luteal phase. Clear? So this is the one that is going to prepare the endometrium for the implantation, at the same time maintains the implantation if it happens, if the zygote, the ovum gets fertilized. So the only one peak of progesterone will happen in the luteal phase, typically on the day 22, but let us see. So in the subsequent minutes, at what time this peak of progesterone will happen. But you can notice the fact that FSH and at the same time your luteinizing hormone, this is the FSH and LH, throughout the luteal phase, they are maintained in a very low range. They are suppressed only. They will not peak at all. That's very important. So there are two hormones which peaks twice, and there are two hormones which peaks only once. So the two hormones that peak twice are FSH and estrogen. And the two hormones which peaks only once are LH and progesterone. FSH has two peaks in the follicular phase itself, one on the day 6 and day 12. And estrogen has two peaks, one in the follicular phase and again in the luteal phase, but the most important is in the follicular phase. And your progesterone has only one peak in the luteal phase. You know why? To prepare the endometrium for implantation and to sustain the implantation if it happens. And only one peak for LH. We know when it happens pre-ovulatory, 24 to 36 hours prior, and we know all the importance of why these LH surges happen in the first place. And why estradiol peaks in the follicular phase? I mean, that's very easy to understand because this estradiol is really important for this proliferative phase of the endometrium, because to make the cells proliferate in the endometrium, you need this estradiol to be there. And similarly, your progesterone is the most important hormone for the secretory phase of the endometrium, where the secretions will happen and they will prepare the endometrium for implantation. And to sustain the implantation and pregnancy, you need this progesterone to be present in the secretory phase, and till the pregnancy is there, you need this progesterone, otherwise child may get aborted. So now let us move on and see the individual hormones, that is FSH. As I told you, FSH has two peaks. One is on the day 6 and second is on the day 12, as I told you. So after that, there is no peaks, only you'll have a low level of FSH in the remaining period. Fine. So what are the functions of FSH? FSH is a glycoprotein, we know that. It comes from the anterior pituitary and it is stimulated by GnRH pulse. I'll tell you what kind of GnRH pulse will stimulate the FSH release. We'll be seeing when you're going to discuss about the GnRH. And what are the functions of follicular stimulating hormone? The function can be differentiated into what are the functions in females and what are the functions in males. In females, the most important function is follicular recruitment and growth. We know that because FSH is the one that initiates the menstrual cycle in the first place. Follicular recruitment, growth and maturation. And it works on the granulosa cells to increase the number, and they're also going to increase the LH receptors on the granulosa cells, and at the same time they're also going to increase the aromatase activity. All these things I have described already, because this increase in the LH receptors by FSH is very important to make the graphene follicle luteinized by the effect of luteinizing hormone in the pre-ovulatory phase. That's really important. So these are the effects of your FSH on the females. These are important functions. What are the importance of FSH on males? FSH is important on males on the aspect of spermatogenesis. Clear? So spermatogenesis is going to be triggered by Sertoli cells. One of the important function of Sertoli cells is spermatogenesis. Remember, Leydig cells are the ones that are going to produce testosterone. Sertoli cells are the ones that are going to be important in spermatogenesis perspective, where usually spermatogenesis happens between two Sertoli cells. Sertoli cells are otherwise referred to as sustentacular cells as well. So you will have a seminiferous tubule lumen here. This is the lumen of the seminiferous tubule. Usually your spermatogoa maturation to produce mature sperms will happen between two Sertoli cells, which is very, very important. And the FSH receptors in the Sertoli cells will be located on the basolateral side. We all know that this will be called as luminal side or apical side, and this sides will be called as basolateral sides. Clear? And the FSH receptors will be present on the basolateral side. Clear? Once the FSH binds to the FSH receptor, the Sertoli cell will start producing something called androgen binding protein. Why they produce this androgen binding protein? Because to have this spermatogenesis, you need testosterone also, which means there will be Leydig cells and they will be producing testosterone, and this testosterone produced by Leydig cells, by paracrine effect, they diffuse and they bind to the androgen binding protein and they stimulate the spermatogenesis. And this androgen binding protein is produced by the Sertoli cells in response to the FSH binding with the FSH receptor. So all these happen, like in synchrony, and nothing can be separate from each other. Testosterone is important for spermatogenesis as well. It's not only the Sertoli cells that are important. This testosterone by the Leydig cells is also important for spermatogenesis. So this is the most important function of the FSH on the males. Then we can see the luteinizing hormone. As I told you, the luteinizing hormone has only one peak, that is a pre-ovulatory peak, 24 to 36 hours prior to ovulation. Clear? What are the nature of LH? LH is also a glycoprotein, secreted from the anterior pituitary. by the gonadotropes, and it is stimulated by GnRH pulses once again. And what kind of pulses? Let us see in the upcoming minutes. And remember, this LH can be inhibited by moderate amounts of estrogen. Moderate amounts of estrogen, testosterone as well as progesterone. Whenever there is moderate amount of estrogen, progesterone and testosterone, LH will be inhibited. But remember, it will be stimulated by high levels of estrogen. Very high levels of estrogen, especially if the estrogen levels are more than 200 picogram per ml. So if it's more than 200 picogram per ml, if it crosses this range, now the estrogen will start becoming like a positive feedback hormone as far as LH is concerned. But remember, FSH can be inhibited by estrogen. But remember, estrogen is not a very important inhibitor of FSH, but the most important inhibitor of FSH is inhibin A and B. In general, inhibin B is the most important compound. And testosterone can inhibit, and progesterone also can inhibit FSH. But remember, testosterone's major influence will be on the LH only. And similarly, estrogen's major influence will be on something else. But remember, this inhibin is the one that is the major inhibitor of FSH in the pituitary. This is very, very important. Clear? Progesterone also to an extent, but inhibin is the most important inhibitor of FSH in the pituitary. But estrogen in moderate amounts can suppress LH, testosterone can suppress LH, progesterone also to an extent can suppress LH, but remember, high levels of estrogen can actually stimulate LH release, and that is the principle behind this LH surge in the first place. What are the functions of luteinizing hormone? So again, we can split into female functions and male functions. In the females, we know it's going to trigger ovulation. It's going to produce androgens, going to trigger the theca cells, and they produce androgens which are further aromatized by the granulosa cells to produce estrogen. And it also luteinizes the Graafian follicle. Luteinizes Graafian follicle to secrete progesterone in the luteal phase. At the same time, it also causes maturation of the primary oocyte to become a secondary oocyte. There are a lot of importance of luteinizing hormone. And in males, it is important for testosterone production. Testosterone production from the Leydig cells. It stimulates the androgen production from the Leydig cells, that testosterone production from the Leydig cells in the testis. So this is the function of luteinizing hormone. Remember, throughout the pregnancy, LH will be in low levels only. You will not have high levels of LH at all, and throughout the pregnancy, your LH will be low. There is no doubt about that. And throughout the luteal phase also, LH will be low. Only that one peak will be seen, that is the pre-ovulatory peak. Let us see the GnRH properties. Gonadotropin releasing hormone properties. Gonadotropin releasing hormone is a peptide hormone. It's not a glycoprotein, it's a pure peptide hormone. It is going to come from the hypothalamus. And remember, it is always produced in pulses only. So this pulsatile production is very, very important, and this is the one that can stimulate the FSH and LH production. For example, if your pulses are of low frequency, usually low frequency pulses will result in FSH production, and high frequency pulses will result in LH production. This is very, very important point again. High frequency pulses will result in LH, and low frequency pulses will result in FSH production. And if you see the pulse release in the follicular phase and the luteal phase, you can see what happens in the follicular phase in the first 14 days is the fact that there are more pulses, which means the frequency is very high, once in 60 to 90 minutes, but they are of less amplitude. The height is low, the strength is low. That's what you see in the follicular phase. And in the luteal phase, the remaining 14 days of the menstrual cycle, you can see big amplitude but widely separated, which means they are of low frequency, like they are done in once in 120 to 200 minutes, but they are of high amplitude pulses. Clearly, this is what is in the luteal phase. This is very important to understand. Remember, continuous GnRH receptor stimulation by continuous GnRH will result in inhibition of FSH and LH release. This is a very crucial property which you're going to utilize in the hormonal treatment of many other conditions. Then we are going to the two important female hormones, that is estrogen and progesterone. Estrogen and progesterone. Clear? Estrogen by nature is a C18 steroid, whereas progesterone is a C21 steroid. Remember, cortisol, aldosterone, progesterone are C21. Estrogen is C18. All androgens, including testosterone, dihydrotestosterone, androstenedione, all these things are C19 steroids. So you have to remember three numbers: C18, C19, and C21. 18 estrogens, 19 androgens, 21 cortisol, aldosterone, progesterone. That's it. So estrogen is a C18 steroid and progesterone is a C21 steroid. As you expect in the menstrual cycle, it peaks at 2 times. The first peak usually happens at day 12. Clear? This is the maximum peak and this is the most important to remember. And usually it correlates with the FSH peak in general. And after 12 to 24 hours of this estrogen peak only, you're going to result in LH peak. And after 24 to 36 hours of LH peak, you will result in ovulation, right? And similarly, progesterone has only one peak, as you notice here, and this peak is seen at day 22, right? We know that. And this is the most important hormone for sustenance of pregnancy. Otherwise, the pregnancy will not be sustained. And let us see the differences between the estrogen and progesterone. What are the effects and the differences between estrogen and progesterone? Remember, reduced progesterone on day 22 in luteal phase, which means day 22 means luteal phase. Reduced progesterone in luteal phase is suggestive of a luteal phase defect. We call it as LPD, that's called luteal phase defect, and it's very important once again to know. And what are the available estrogens in the body? You have estriol, estrone, and estradiol. So for that matters, your ovary is going to produce estradiol. Ovary will produce estradiol and a small quantity, this is the major hormonal component of ovary, and in a small amount they are going to produce estrone. And adipose tissue is going to produce more of estrone because of aromatization of the androgens, and fetal liver produces more of estriol. So all these are MCQs in exam. Clear? All these are MCQs. Estradiol, major source is ovary. Adipose produce more of estrone and fetal liver produce more of estriol. Difference between estrogen and progesterone on the effects. What is the effect on the uterus? Both can produce myohyperplasia, but most important effect of progesterone is to reduce the contractility of the uterus. That's the reason why it is important for sustenance of pregnancy. Both can produce myohyperplasia, but effect is more towards estrogen compared to that of progesterone. And endometrial changes, they produce proliferation, increase the growth and vascularity of the endometrium, which means they are going to result in a proliferative endometrium. Progesteronic effect on endometrium will be on gland secretion or glandular secretion, which means they are going to result in a secretory type of endometrium. And cervical changes with estrogen. Cervix is going to produce increased secretions, and those secretions will have thin mucus which will be elastic, isn't it? In your obstetrics and gynecology, they would have clearly shown an image also. That's called a spin bark, isn't it? The pre-ovulatory or ovulatory mucus will be like very thin, and you can stretch it up to even 8 to 10 centimeter, called as spin barky. That's a thin mucus. Whereas progesterone will reduce the secretions of the cervix. At the same time, they will make the mucus thick, at the same time non-elastic. Vaginal changes of estrogen. Vagina will show more of superficial keratinized cells. Superficial keratinized cells along with glycogen deposition. whereas progesterone will result in formation of intermediate cells in the vagina. I mean, these are based on the histology. And effect on the breast. So estrogen will result in growth of duct and stroma. In other words, I can call it as ductal growth is influenced by estrogen, whereas progesterone is more important for the lobulo-alveolar growth of the breast. Cardiovascular system, estrogen is well known to produce vasodilation because of the local nitric oxide production. Remember, high estrogen in cirrhotic patients is the main reason why they develop this palmar erythema because of vasodilation, and spider angiomas again because of vasodilation. Because this spider angiomas and this palmar erythemas are thought to be hyperestrogenic effects causing vasodilation. That's why I was actually substantiating this vasodilation point. And they can cause water and salt retention. We don't know the exact mechanism by direct effects or indirectly by little bit slight augmentation of the RAS system. Progesterone is also going to cause water and salt retention. And effects on the hypothalamus and the pituitary, obviously they are going to inhibit FSH. At the same time, they are going to stimulate the LH surge. But remember, to stimulate the LH surge, you need extremely high levels of estrogen. The levels already I have mentioned. Moderate levels will inhibit LH only. But this inhibition of LH will happen at moderate levels of estrogen. Progesterone, I mean, they do inhibit FS in LH, but the most important function of progesterone is to modulate the GnRH pulse, both the amplitude as well as the frequency, rather than at the pituitary level. Skeletal effects or the bone effects, they are going to increase the osteoblastic activity, they are going to reduce the osteoclastic activity, they are going to reduce osteoporosis by the same, isn't it? Because by increasing osteoblastic activity and decreasing osteoclastic activity, they prefer and promote bone formation rather than bone destruction. That is why they are protective against osteoporosis. And this is the same reason why when estrogen drops after the menopause, the women are more prone for developing osteoporosis. And there can be fusion of epiphysis, and this is a very important point because estrogen is known to produce fusion of epiphysis even in males. The modern theory tells the same. Testosterone actually tries to expand the bones and increase the bone length, but estrogen in males is trying to close the epiphysis, and it's been proven that estrogen is the reason for closure of epiphysis. That's really important. And this is also the reason why you develop typical female type skeleton, like a narrow shoulder and a narrow hip, converging thighs with diverging arms. That's what it is. Narrow shoulder and hips with converging thighs and diverging arms. So this diverging arms is going to translate into your clinical finding as wide carrying angle. That is why ladies have wide carrying angle. And obviously, progesterone is going to activate the osteoblast even though the effect is very, very weak. And there are some effects on carbohydrate metabolism as well. In the carbohydrate metabolism, they slightly reduce the fasting glucose, not much, whereas progesterone is thought to reduce the glucose tolerance, and probably it might produce glucose intolerance also. That is one reason why probably a pregnant mother may be more prone for getting a gestational diabetes mellitus, but this is not the sole reason. Placenta is also the reason, but progesterone just plays a part in developing this GDM, gestational diabetes mellitus. The lipid effects, estrogen has beneficial effect on lipid profile, like they are going to reduce the LDL, and they can reduce the triglyceride, and they can increase the HDL cholesterol, which means they are protective against atherosclerosis. That is also the reason why till the menopause is reached, like the women is having much lesser risk of cardiovascular death or cardiovascular risk like myocardial infarction in comparison to males. Once they go towards the postmenopausal age, women has almost equal chance of getting the problem as equal to that of the males. So that is because the estrogen loss in the postmenopausal women. Very important point. And the progesterone is known to reduce HDL. At the same time, they are known to reduce the LDL also. But the effects are variable and not so clinically important. And effects on coagulation profile. Estrogen is known to increase the procoagulant activity, like they can increase the levels of factor 2, 7, 9, 10, but not through vitamin K mediation. It is completely different on the liver. So they're going to increase the levels of factors 2, 7, 9, 10, and the same time factor 12 also. But they reduce anticoagulant factors like protein C, protein S, and antithrombin 3. That is the reason patients who are receiving oral contraceptive pills, especially those which containing estrogen, are at high risk of developing deep vein thrombosis and cerebral vein thrombosis and other complications, because their profile is more towards procoagulancy rather than anticoagulancy. Whereas there is very, very negligible effect on the coagulation profile as far as progesterones are concerned. That is also the reason people who are prone for this procoagulation, like people who are prone for this DVT and pulmonary embolism, if you want to use a contraceptive pill, you can use progesterone-based pills rather than this estrogen-based pills. This is a very important point again, because progesterone has not favorable, not unfavorable, which means it has a neutral profile on coagulation profile in comparison to estrogens, which has unfavorable profile on coagulation. Then neurological effects. Estrogen may play a role in cognition, proven in some studies, and progesterone is thermogenic. At the same time, it can induce depression in women. That's why postpartum depression is very common in females, partly due to progesterone, not only due to progesterone, but partly due to progesterone. And you have pregnancy effects. Pregnancy estrogen is not that important, but I told you the most important hormone of pregnancy is progesterone only, where it is important for maintenance and sustenance of pregnancy. Clear? There are a lot of other factors that are also involved in the female. So like for example, you have IGF-1, which stimulates gonadotropin-induced steroidogenesis. So production of this sex hormones is very, very important. IGF-1 stimulates the gonadotropin-induced steroidogenesis. And you have transforming growth factor, beta, TGF-beta, and epidermal growth factor, which are very, very important for granulosa cell proliferation and differentiation. And interleukin-1, it is thought to be anti-gonadotropic, and it will control the granulosa cell luteinization after the LH surge. And you have inhibin as well, which can inhibit FSH. Remember, the most important agent that inhibits the FSH, I told you multiple times, is inhibin. It has two molecules, inhibin A and inhibin B. Both can powerfully inhibit the FSH release from the pituitary, and can also stimulate the ovarian androgen production, because FSH is important for estrogen production by activating aromatase. You can understand inhibin will produce opposite. Instead of estrogen, they will stimulate the ovarian androgen production. There is another compound called activin. Activin can stimulate FSH. It's opposite to that of inhibin. They will stimulate FSH release, and they're going to stimulate aromatase activity, because by increasing the FSH levels. At the same time, they can also stimulate the progesterone synthesis also. And finally, you have another compound called follistatin. This follistatin is going to bind activin. It is like a neutralizing agent of activin. So it's going to bind activin and to stop from acting, which means they are going to inhibit FSH, because activin is going to stimulate FSH. This follistatin, by binding with activin, they inhibit the FSH. At the same time, they are also quite important for this oocyte maturation process. So these are the functions of other factors other than the hormones that we have discussed in the ovary, and even in the males, these are the same things that is happening and important as well. But from the male perspective, that's all. And estrogen acts via two receptors. We know that. We don't know what is the real role of these receptors, but estrogens act via two receptors called as ER alpha and ER beta. ER alpha and ER beta. So remember, both ER alpha and ER beta are seen in the uterus, kidney, even though the exact effects of this ER alpha and ER beta are unknown, but ER alpha and ER beta both are seen in the uterus, kidney, liver and the heart. Whereas this ER beta alone is seen in the ovaries, prostate, lungs, gastrointestinal tract, central nervous system and hematopoietic system. But we don't know the real reason of what is the real function, or is there any real functional difference between ER and alpha and beta. Even the experiments are going on. A lot of experiments have been proven that ER beta knockout will result in like regression of the benign prostatic hyperplasia. For example, if you give ER beta antagonist, so your BPH will reduce and the prostatic size is reducing. And ER beta knockout mice tend to be sterile, usually, especially if it's a female, but ER beta knockout in males has no effect. But ER alpha knockout will result in sterility in both males and females. These are rat experiments. But still experiments are going on, but we really don't know what is the real and true function of ER alpha and ER beta. Remember, estrogen being steroid hormones, they are going to work inside the cell, which means they are intracellular receptors and they are going to have intranuclear receptors, and they are present within the nucleus. Once estrogen binds with this ER alpha and ER beta, they are going to bind with the new DNA, and in the DNA they are going to activate certain transcription of certain genes, or they are going to inhibit the transcription of certain genes, and that's how they regulate the cellular expression of proteins. So that's how estrogens are going to work, and these are the differences between estrogen and progesterone. Finally, a small word on male spermatogenesis, because it's a sin otherwise. I have to discuss on male spermatogenesis also. So how the spermatogenesis happens, first of all, let us see. This is the testis. If you take the testis, you have this cortex of the testis, which contains multiple tube-like structures. These are called as seminiferous tubules. And in the medulla, you have a structure called retitestis. We are not going to discuss about that. And when I'm going to cut this seminiferous tubule and see it in cross section, and this tube is going to look something like this. So because it's a tube. So this is a single seminiferous tubule. So now what I'm planning to do is I'm planning to take a cut section of this wall of the seminiferous tubule and try to expand it further. And let us draw the lumen of the seminiferous tubule. So this is considered to be the lumen of the seminiferous tubules. And let us draw the Sertoli cells as well. You know that spermatogenesis is going to happen in between the two Sertoli cells under the influence of FSH on the FSH receptor. Remember, testosterone is not a powerful inhibitor of FSH by feedback, because the Sertoli cells are going to secrete two substances. One is inhibin and anti-Mullerian hormone in response to FSH. So this inhibin is a very, very, very strong negative feedback regulator of FSH, not testosterone. Testosterone is a weak inhibitor of FSH. Only at high concentration it can inhibit FSH, but testosterone is a ready inhibitor of LH, because LH causes testosterone production. So naturally by feedback they will inhibit LH first, but inhibin is the most important negative feedback that is for FSH, not the testosterone. And remember, spermatogenesis is a continuous process, and average to produce a sperm it takes approximately 64 days. That's very important till the maturation is over. So let us see that later on. So it starts with the primordial germ cells, the same primordial germ cells that start in the yolk sac and that originate from the yolk sac and migrate from the hindgut and enter the gonads under the influence of WNT and this SDF1. The same primordial germ cells they're going to produce a pool of stem cells called spermatogonial stem cells. These spermatogonial stem cells, occasionally some of the cells will leave the pool to replenish the sperms, and they produce something called a type A, dark type of spermatogonia. So these are called as type A dark spermatogonia. And this will once again go for mitosis. Remember, the nuclear configuration will be the same, 2n and 2c, diploid, and 2 chromatids. And they'll go for mitosis, and they'll produce 2 different types of spermatogonia. One is they produce clones of type A spermatogonia, which are also referred to as pale type A spermatogonia. These are nothing but clones of type A spermatogonia. That's all. To have multiple clones means your spermatogenesis can happen continuously and indefinitely. That's the reason. So now the last of the cell divisions will form a new type of spermatogonia called as a type B spermatogonia. That's a second type of cell due to the result of this mitosis. And this type B spermatogonia will now undergo mitosis, like how oogenesis produced a primary oocyte. Like that, this type B spermatogonia will go for mitosis, where there will be DNA replication but without any cell division, which will result in a primary spermatocyte. Remember, the type B spermatogonia also has a 2n 2c configuration, but this primary spermatocyte, because of the DNA replication but without cell division, they will become a 2n and 4c, 4 chromatids. The DNA has replicated, but the chromosome itself has not divided, and your cell has also not divided much, so resulting in a primary spermatocyte. This primary spermatocyte, now it will undergo meiosis 1. Obviously, it's going to half the nuclear material now, and they form 2 secondary spermatocytes. Secondary spermatocytes, where the nuclear material will be halved now, N and 2C. And this 2 secondary spermatocytes will become 4 spermatids. 4 spermatids due to meiosis 2. And obviously, when meiosis 2 happens, obviously your nuclear material is going to become, half again. So it will become N and C. For each spermatid, it will become N and C. It will be shared, right? This is the whole purpose of meiosis, isn't it? So N and C now. It happens in any organism, any reproductive system, you're going to expect the same. And these spermatids are not ready to release into the circulation. Before that, these spermatids has to undergo a process called maturation. This maturation has 4 steps. One is called a Golgi phase, where there will be formation of acrosomes. Second one, acrosomal phase. The formed acrosome will consolidate. And the third one is the tail phase, where there will be centriole formation. And fourth one, maturation phase, where there will be cytoplasmic loss. And finally, the mature sperm will be formed. And this maturation process is what we refer to as spermiogenesis. And once the sperms are matured, they will be released into the lumen. This release into the lumen is called by a separate name called spermiation. Clear? Release into the lumen is called by a separate name called spermiation. And once they are released into the lumen, they will be stored in the epididymis. So in the epididymis, they gain motility, which is a further part of maturation. And once they are ejaculated, once they enter the uterine fluids, further maturation will happen. That is called as capacitation. So many processes are involved. Clear? Initial maturation, then gaining motility, further maturation in the epididymis, and finally capacitation happens in the uterine fluid after ejaculation into the vagina and the cervix. Clear? So this is the entire process of spermatogenesis happening. The number is important at the same time. Remember, it's a continuous process. It happens continuously, unlike your oogenesis, which is happening only for a limited period of time. Remember, you can imagine this primary spermatocyte as a analog of primary oocyte, and the secondary spermatocyte you can imagine like analog of secondary oocyte. Clear? And you can remember that your spermatids are analog of ovum. So something similar to that. So finally you have NC configuration. So where ovum will also have NC configuration, both will join together to form a 2N and 2C back to the square diploid chromosomes. So this is very simple, and that's how it happens. And what are the effects of testosterone? We have not discussed this one thing finally. So this is the last one I'm going to discuss. What are the effects of testosterone? Obviously, it is the single most important hormone for producing this male sexual characteristics. Remember, not only for male sexual characteristics, for male gender identity. As I explained to you in the previous video, for making a male gender identity by a child, this testosterone is really, really important. Clear? At the brain level, it acts, even at the embryonic stage. Fine? So a lot of male sexual characters like external genitalia virilization in a male is due to testosterone and dihydrotestosterone. And formation of male internal genitalia in a fetus is due to testosterone and dihydrotestosterone. And probably your male pattern voice, that's called deepening of voice. It is due to testosterone only. And testosterone has a lot of anabolic effects as well. Anabolic effects like it can increase the muscle mass. At the same time, it can cause bone growth. Closure of epiphysis is very controversial. We don't know whether it really causes closure of epiphysis, because according to modern studies, closure of epiphysis is probably due to estrogen and not due to testosterone, but clearly produces bone growth, no doubt about it, and increase the muscle. And that is the reason why many bodybuilders use this testosterone for building their body, and it's one of the doping agents, isn't it? It gives that strength, agility, aggressiveness. So that's the reason it's one of the abused drugs. So it's a banned drug, it's a doping drug. Testosterone is known to increase the libido as well. Testosterone can promote spermatogenesis. But remember, as I told you, testosterone is important for spermatogenesis, because spermatogenesis, even though it happens between two Leydig cells, testosterone diffuses from the side, coming from the Leydig cells, and stimulates spermatogenesis to happen by paracrine effect. That's a very, very important point. Testosterone stimulates the spermatogenesis happening in between the Sertoli cells, because testosterone comes from the Leydig cells and exerts its effect on the Sertoli cells through paracrine effect. That's a very important question. Not systemic effect through the blood, but through paracrine effect on the Sertoli cells. At the same time, it's important for the hair growth. Even in females, the androgens are important for hair growth, pubic and the axillary region. So in males, the pubic hair growth, axillary hair growth, and the beard growth, all these things are based on testosterone only. There are some peculiar effects on dihydrotestosterone. Remember, dihydrotestosterone is more important for external genitalia virilization in fetal life. At the same time, dihydrotestosterone is important for male pattern hair loss or male pattern hair, where you'll have a anterolateral recession. This is called a V-shaped pattern. You have an anterolateral recession of the hairline. So this is typically due to dihydrotestosterone, and these areas are very, very responsive to dihydrotestosterone. And sebaceous gland activity. Remember, testosterone is supposed to produce thick sebum, and that is the reason why they are prone to develop acne. Whereas your estrogen is tending to produce a fluidic sebum, and that is the reason estrogen is against acne, but testosterone is definitely acne-inducing agent. And because the male pattern hair, it doesn't only cause male pattern hair, it also causes male pattern baldness. At the same time, dihydrotestosterone is very, very important for prostatic growth. That is why 5-alpha reductase inhibitors are very useful for benign prostatic hyperplasia as a pharmacological therapy. So these are some of the effects of testosterone and dihydrotestosterone. With this, we are completing the most basic topic I think this made a bit of sense. I think many of you would have known this already. But if you have not known this, hopefully this topic would have helped you understanding this. But with this, I am signing off with this topic. We'll move on to the next topic on adrenal steroidogenesis, which is going to be much, much more interesting, and it's one of the most important topics to understand congenital adrenal hyperplasia and disorders of sexual differentiation.